Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello and welcome, listeners. This is Kevin MacPherson, and today we are speaking about an article titled Influence of Residency Training on the Clinical Reasoning Development of Kenyan Physiotherapists. We get to speak to Shala Cunningham, the primary author for this article, as well as Richard Jackson, who has been a driving force for this program in Kenya. Now, before we get into the article, let's give you a brief background on our two guests, starting with Shala. When you look at Shala's CV, you will see that she is apparently addicted to learning, having completed her Bachelor's of Science in Physical Therapy from Indiana University, 2 manual therapy residencies, as well as a fellowship through the Ola Grimsby Institute. She also completed the OGI Doctor of Philosophy in Orthopedic Manual Therapy, as well as a transitional doctorate of physical therapy from Arizona School of Health Sciences, A.T. Still University. And her most recent acquisition to that learning pedigree is a Doctor of Philosophy through Nova Southeastern University, which was accomplished just last year. Now, her counterpart in this interview is Richard Jackson, who has a very different background, but arguably just as influential. His background includes 50 years or nearly 50 years of practice in physical therapy. He is the president and executive director of clinical services for his company, Jackson Clinics, which has 21 locations in Northern Virginia. His background also includes a few other non necessarily practice related awards. One is being his honorary Doctor of Science degree from Shenandoah University, which he does provide faculty services for. He also has a Private Practice Section Award Practice Award from 2010, and APTA proper also has celebrated him with the Societal Impact Award specifically for his educational development work within Africa. So before we get into the article, tell me how you guys are doing today.
I'm doing well.
Very good, very good. Thank you for putting this together, Kevin. Looking forward to it.
And I'm definitely grateful for both of you guys being able to meet together at the same time, which is not always the easiest thing to do for a podcast, especially when both of you are in different locations. So let's just dive into it because there's a fair amount to cover with this specific article, but I don't think it would be out of place to try to put a little bit of context. And one of the obvious items that a reader will observe with this specific article is the location of the residency. And as you dive into it, the instructors that are spoken to specifically in this article are more US based, or at least the program seems to have a US base. I believe that question is best answered by Richard. Do you mind telling us a little bit more about this program?
Yeah, gladly. We were, my wife and I, Anna Jackson and myself, we started a nonprofit foundation a number of years ago. We originally started educational projects in Ethiopia, and in 2012, we were invited to come to Kenya to talk about starting an educational program there. I should say that I was a Peace Corps volunteer in Kenya at the Kenya Medical Training Center, now Kenya Medical Training College, in the late 1970s. The Kenyans wanted two things. One, they have a diploma program, which is 3 years out of high school, and then you're a physiotherapist. They wanted an upgrade to a Bachelor of Science degree. For our foundation, that was not possible immediately. And the bottom line for them was they wanted to improve the clinical skills. Now, as a Peace Corps volunteer in the late 70s, that was before the manual therapy revolution, for those old enough to remember the start of that revolution. Um, and it was all pre 1980. It was pretty much all modalities and exercise in physical therapy. What we found in 2012 when we were invited was that it was still a modality based situation. And then you have to ask yourself the question, why? Why didn't they progress? Well, if you have a small country like Kenya and one educational institution, Kenya Medical Training College, and there are occasionally individuals do go on and get a bachelor's degree, which is not necessarily in physical therapy, or they'll go on and get a master's degree, which is not necessarily in physical therapy. From the late 70s until 2012, what would have changed the education? And Shala and others can attest to the fact these are highly motivated, very smart individuals who thirst for education. But what would have changed it? What would give them the access to what we have? And if you look at the scope and breadth of physical therapy today, it's a pretty massive amount of information. So uh, we literally supply access to education. We send teachers. There are teachers almost every week of the year. We have teachers in Kenya. We have two of them teaching therapeutic exercise right now, and three showing up Friday this week for a 2-week program in women's health. So we thought, well, it is a massive amount, so we'll start with orthopedics. And we started with 6 modules. And this program um, is a bit different in that they are 2-week modules. We have to give didactic education in a residency program. So that's given initially in 12 weeks, 2 weeks every 3 months. So it takes them a couple of years to get through the program. We now have 7 modules. We added one. Um, and then there's clinical mentoring. So we send mentors, and we have a number of individuals who are at a point where they can mentor. We teach in Nairobi, but we need upcountry mentorship. So the Jackson Clinics Foundation has one employee in Kenya, a Kenyan physiotherapist whose job is to run our program on the ground and to travel throughout the country to do mentoring. Um, we also need sustainability. So our goal in any of our programs, whether it be Ethiopia or Kenya and soon to be in Mozambique, our goal is sustainability. So this past year, for the first time, the orthopedic modules have been taught 100% by Kenyans. We've also gone beyond the orthopedic into neuro, other specialty courses. We're developing a sports medicine program. We'll have a vestibular educational program in March, I believe. And we've launched the women's health program. So that's a long answer to a short question. We got there by invitation. We supply access to education, but it has to be comprehensive. You know, schools will send students for a couple of weeks and they're in and they're out. And the question is, what long-term benefit does this have to the host country? Our intent is to have long-term benefit. Shala, I don't want to speak for her, but I'll give her a little intro here, is that I think Shala was in our first year in Kenya. It might be the second year. And uh, she thought this has some real potential. This has legs to it. And went ahead and got a grant to do the research that she's been doing on our outcomes.
When I read more about this program, the more you get the feel that you're really taking the tact of teaching how to fish as opposed to giving a fish, which arguably is the two descriptions or the two distinctions between sending students and maybe creating a program, but trying to build your instructional team from the area that you're going into.
You're exactly right. It took 7 years to get to a point where the Kenyans could teach this. So it's really, in projects like this, a real long-term commitment.
And I'm sure that's a commitment that we're getting ready to hear a little bit about how it's evolving, the clinicians over there. So we'll move on to Shala for this question. Let's talk about the outcomes. Let's talk about the research that you've done so far, and just give us an idea of what the project was and what results you came to.
Yeah, so for this research study that we're talking about, we really wanted to explore the clinical reasoning development of the physical therapist participating in that 18-month orthopedic residency program. And so to assess the clinical reasoning, we looked at them when they entered the program before they started any of the modules. And then we assessed them again as they completed all the modules and then their final live patient examination. So to assess their clinical reasoning, we evaluated a live patient examination, very similar to what you see in residency programs in the United States. And our live patient exam was based on 64 skills or behaviors that are associated with the description of specialty practice in orthopedics. And we categorized those skills into the categories of examination, evaluation, diagnosis, prognosis, and then intervention. And then on our form, each of those behaviors could be scored as satisfactory performance, not satisfactory performance, or not applicable to the patient. So since we were using live patients or patients that were coming in for evaluations, we weren't sure if every skill or behavior would apply to that patient. So we did have the option on scoring just to say, not necessary. And then at the very end, there were 6 items on our assessment form that were consistently not applicable either at the beginning of the program with that patient or at the end of the program with their final live patient exam. So somewhere along the line, each resident had a not applicable on one of those 2 exams. And so we had to remove those 6 items because there was no place for them to grow if one end wasn't applicable for them. So we ended up with 58 items on our assessment. And the residents did very, very well. They demonstrated a statistically significant change on 17 of those items. And there were another 36 of those 58 items that had a positive change in the median, but not a statistically significant change. So when we look at the items individually, they improve, but I think the main impact came when we looked at their overall score for the assessment tool. So if we were to grade the entire tool and give them a score, their scores improved by, on average, by 45%. So that was a significant change overall in how they were doing.
Yeah, I mean that sounds like a huge jump. And this tool, I'll be openly honest with you. Ahead of reading the article, I wasn't familiar with the tool. Shala, you were involved with creating this tool. Is that correct?
Yeah, I wasn't necessarily the creator. This tool's been handed around orthopedic residency programs for many years.
Okay.
And so if we look at it, it's based on the description of specialty practice in orthopedics. And when the description of specialty practice first came out, there was the self-assessment tool that came with it.
Mm-hmm.
And it looks like this assessment form was actually based on that self-assessment tool. And Richard and I went around looking for the original source of the tool.
Mm-hmm.
And we went to the APTA and we went to AMPRI and we were asking, does anybody know where the original tool came from? And to the best of our ability, we were able to trace it back to Joe Gotches.
Mm-hmm.
And so we started talking with him as well about this tool. And so we received the tool from him, and originally the tool was 81 items. And if we wanted to use this for a summative assessment to grade the residents, we had to get inter-rater reliability, intra-rater reliability, and some type of construct validity on the tool. So we knew it was being used, but we couldn't find anybody that had looked at the psychometric properties of it. And so that's where we started. And then in the end, we ended up with 64 items. There were some items on the original tool that we just weren't going to see in Kenya. And if we did, it definitely wasn't the focus of our program. There was a lot of modality questions. So ultrasound east and diathermy was on there, lots of taping techniques. And so they didn't translate over.
Okay, so not so much the creation, but you were more involved with those psychometric property measurements, and then really honing that tool down for what you needed. Correct? Am
Correct.
I okay? All right. Now this also had a little bit of a different spin to it. This was a mixed method study. Do you mind describing what that means and what your take home was from the other portion of that type of study?
Yeah, so when we look at mixed method studies, we're just looking at the collection and integration of both quantitative and qualitative outcomes. So our quantitative outcomes was this assessment tool that we utilized to look at the residents' clinical reasoning. And since we pre-developed that assessment tool, we already had um, a construct in our mind of what we thought the residents would do. And we wrote out these very specific skills. And we had to be able to observe the resident perform the skill in order to score it. And then the qualitative component included those parts of clinical reasoning that you can't visually see, which is the thought process of the resident. What were they thinking? How were they developing their thoughts? How did they get from point A to point B? What was that hypothetical diagnosis? Did it change over time? And those are things you can't visualize. So in our qualitative component, we just used open-ended questions, and we asked the resident what was their hypothetical diagnosis for this patient, or what was their primary impairment that they noted for the patient. And then we just simply asked them, how did they get to that point? Explain your process. Um, and what we found when we used the assessment tool is that the residents increased significantly on the number of cues they collected in the history. So they went from collecting 36% of the cues that were available in the histories to about 81%. And so if we just looked at that tool by itself, it looked like they were using the hypothetical deductive reasoning method. They were collecting cues and then integrating it to a hypothetical diagnosis. But when we talked to them about what they were doing in that history, they described needing to understand the patient's story and needing to understand the patient's perception of how these impairments affected them, and needing to include the patient in on the treatment plan, and making sure that they individualized their treatment to fit that specific patient. And that's not the hypothetical deductive reasoning model. That's narrative reasoning. So what we saw was this improvement in all these skills. But when we talked to them, they were using a completely different reasoning process, or they were at least overlapping them.
And that speaks to another large body of research that I believe you quote in that article. I know that the main researcher, typically the last author being Gail Jensen, uh, can you give us just a little bit of insight relative to that clinical expertise framework that they worked on and how that relates to this project and your findings?
Yeah, so when we look at clinical reasoning development, we think of novice therapists starting with the hypothetical deductive model, that they're going to use exhaustive cue acquisition. And then the end, they're going to take these series of cues and start to develop this hypothetical diagnosis. And it's very well structured. They're going to go through each component. And then when we think of expert clinicians, we think of things such as pattern recognition. So recognizing what is happening right away with the patient by talking to them, and then jumping to those tests and measures that would either verify or refute that diagnosis right away. And then we also see a lot of narrative reasoning coming in, that the expert clinicians are able to incorporate that patient's story, and make things very individualized to get the maximum outcomes. And so, what a lot of the research points to is that an expert clinician doesn't just use one form of clinical reasoning, that they mix and match these different methods. As they go through the patient evaluation, they might start with one form of reasoning. They might start with the hypothetical deductive model, see a pattern, and then incorporate narrative reasoning. So the therapists in Kenya, by incorporating two forms of reasoning, were very much in line with what we're seeing with expert practice.
And that expert practice appears like, when you just take it at face value, seems to be a lot of that ability to take in the big picture, which brings me to a question for Richard, since he's kind of a heart and soul when we look at this program. Richard, tell us a little bit more, if you can, about the other qualitative measures that you might have picked up more anecdotally or more off the side. What did the therapist say to you, or what kind of feedback have you gotten about, just how they feel about the process and how they feel about their ability to just practice in general?
Oh, wow, what a great question. There's palpable excitement throughout the country over the program. Kenyatta National Hospital is the largest hospital in East Africa. It's right directly across the street from where we teach. They have 65 physiotherapists in the hospital. 16 are assigned to outpatient orthopedic physiotherapy. The director of the physiotherapy unit has insisted that only our graduates will work in the outpatient orthopedic because their observation of outcomes, um, and the actual request from patients to only be seen by an OMT, orthopedic manual therapy graduate, um, to meet the demand. They have literally doubled the size uh, of the department to meet the demand for our graduates. So when I talk to people, graduates of the program and individuals in the program, they're very graciously thankful for giving them the gift of confidence that previous to the OMT program, they would listen to the patient and then apply the appropriate modality to the affected tissue. Uh, they now have confidence that they know what to do, and they have a menu to select from as in terms of evaluation and treatment. It's absolutely wonderful to see the transformation.
I mean, and that goes back to more of that core statement from, arguably APTA, but by national or by international standards, the World Congress of Physical Therapy, looking at our hope to just transform society. And you're giving us a very solid example where it sounds like the program, the society is just really evolving on that program. Does that seem to be health wide, or is this more physiotherapy centric?
I would say physiotherapy centric.
And that's amazing to see. Uh, it's amazing to see something that can seem as a nebulous statement to a lot of individuals actually being uh, given a real concrete example in real life.
Yes, the gift of education and the gift of confidence is just so exciting to be able to provide and to be able to see the effect on a country. Um, in Kenya, Ethiopia, uh, and soon Mozambique are small enough countries that we've been able to actually transform rehabilitation services throughout the country. It's quite wonderful.
So now, Shala, this question's coming to you, and it's kind of to help our listeners bridge a little bit of a gap in this article relative to at least one other article, and that's Jason Radagiro's article, where it really didn't see a robust change in outcomes or cost of care for residency training compared to entry level training. And again, I see that's the standard US model. So, how is our listener supposed to kind of take the information from this article, take the information from that article, and make a story that they can follow?
Yeah, I think the big thing that we found in this research study was that clinical reasoning did evolve and clinical reasoning did improve. And if we think of clinical reasoning kind of being the hallmark of expert practice, then that is evolving as students go through the residency program. And in this program, it was unique in that none of our residents had outside continuing education or other outside influences that would kind of muddy the waters on whether it was the residency or all the continuing education they had taken, because that can get quite nebulous in itself. So our residents just only had residency training, but it did improve. And as clinical reasoning improves, we would hope that patient outcomes would improve. We didn't look at that with this study, but we have followed our graduates several years out, and they are noticing kind of from a qualitative standpoint, they don't have robust documentation there that their patient outcomes are improving. And just as Richard said, the outcomes are improving such to a point that employers and patients are seeking out those residents for treatment. And I think what happens when patients and um, physicians and referral sources are seeking out specialists, those specialists are going to get more complex patients just by the nature of the referral. And that may in some way be impacting outcomes.
Kevin, if I may, you have to bear in mind that the difference in the research on US-based residency programs and the Kenyan residency program are that US-based physical therapists share a common standard of education, modern, comprehensive physical therapy education, from which a residency program springboards. In Kenya, um, you were practicing in the 70s. You were practicing with only modalities. And if the electricity went off, physical therapy stopped. And virtually no therapeutic exercise. So it was even further behind. If you then walk in and give modern physical therapy education and give people the skills to think and to reason clinically and give them manual techniques and exercise techniques, there's going to be quite a change. I think that's the primary difference is we're starting with the most basic education imaginable in physical therapy and then giving them today's modern education and saying, is there going to be a change? Yeah, there is.
And that, Richard, was kind of what I was thinking. Your line of thought on that was definitely what I was thinking. But I think Shala also made a really good point about the possibilities of clinical education, that's my role as a faculty, continuing education, also muddying the waters. That's a different angle that I hadn't thought about. And I think that's very important for the listener to also, when they look at Radagiro's work on this, to consider. But um, you know, very descriptive, Richard, when you're talking about the power going off prior to instituting this residency program. And just to try to put myself in that position with my background and not eliminating that knowledge, I just don't know how I would respond to see that in action, to see that actually happen. Uh, stories make they make us look at the world differently. So So Shala, the next question is more for you. However, Richard, by all means, feel free to jump in. Shala, I see that you're a fellow. One of the questions we like to ask our guests that are fellows within the association is, what insight would you give to somebody who's considering doing a fellowship? And for both of you, we can change that a little bit around as well and say, in context of the article, what would you say to somebody who's considering residency training?
Yeah, I would say anybody considering residency or fellowship training, I would encourage them to really reflect upon and explore their goals for pursuing that advanced training. What is it they hope to get from that program? How is it going to affect their career advancement? How is it going to affect their professional development? And I think if they can be honest with themselves on what it is they're looking for and what it is they want from a program, that's going to help them choose a program that best fits their needs and will help them meet those goals.
And Richard, did you want to add anything or?
Yes, I, as a clinician, all clinicians want their their patients to get better, and all of us are learning through years and decades, and all of us at times uh, at night wonder about this patient or that patient, and did I do the right thing? I think what residency and fellowship education gives is concentrated clinical insights. It really goes back to the gift of confidence that you just have a bigger toolbox and you're much more confident in your knowledge and skills because you've been through specialty training. Confidence in the clinic is everything, I think. Um, Keeps you sane, that's for sure.
Very, very valid and very well received responses from both of you guys, and very appreciative. So, in order to keep our listeners up to date, we'll start off with you, Shala, given you're the primary author on this one. Do you have any other projects in the works that you think our listeners would benefit from keeping an eye out for?
Yeah, definitely. If individuals are looking at developing programs in resource limited countries, with the help of Richard, we've been looking at the barriers and facilitators to putting a residency program or advanced training in place. We have some articles on the cultural differences. The United States is a low context culture, so we take everything very point blank, and we're very direct with our communication, and we do very well with online education. And most countries that are resource limited are high context cultures, and they don't do as well with that. They need the relationship. So we've been looking at what types of things Richard has been able to integrate into this program, um, to create an environment of learning for these students and for his residents. So we've been working on that, and then we're looking at the long-term outcomes. So we're going through and interviewing these residency graduates 2 and 3 years after they've completed the program to see if their practice actually has changed. Have they taken these skills and integrated them? And if it has changed, how and what's this long term impact? And I think with any program that you put in place, you can get the snapshot, which is what we have here. Yes, pre and post their clinical reasoning improved, but that's not necessarily the impact. And so I think what we're looking at now is for that impact of the program.
Very interesting, and I look forward to seeing that info come out. The part you talked about with that high context versus low context is definitely something to reflect on. I did a small qualitative study for fellowship, and one of the things that came up with the background was how to create uh, or help somebody finish a program. And it seemed like having relationships came into play, which arguably would be huge for creating context. And that wasn't even in a physical therapy environment, that was just looking at online degrees. So I'm very interested to see what else you reveal more specific to our profession. Now, Richard, you've already talked about expansion of your program, but is there anything else that you've got going on or that you'd like to elaborate on for our listeners?
Well, I think one of the more interesting things we've been doing, uh, we started in Ethiopia with the first doctoral program in physiotherapy on the continent of Africa. And what we introduced there uh, was the concept of a physiotherapist who is a primary care giver, that our physiotherapists there um, took classes in medical school. They go through medical school with the medical trainees, and they took trauma. Um, our graduates have the ability to set fractures, suture wounds, give injections, prescribe medication. When you look at the DPT education today, where it exists in the world, it's a small step to take to be able to do so much more. And we've met with the individuals university in Mozambique, and uh, to turn out physiotherapists who are primary caregivers, experts in neuromuscular uh, care. um, they selected that. Now, Maputo, Mozambique is adjacent to South Africa, and it's going to be interesting to see when the program eventually launches how many physios from South Africa are going to get their DPT in Mozambique. I think it's an interesting concept that may get legs throughout the world to develop DPT practitioners who can do more than what we're doing today. So I think that's exciting.
Yeah, I will 100% agree with that one as well. The thing that I try to teach the students here at the university I teach at is to try to look at patients and look at patient care from a primary care, primary access point vantage point, which is difficult since we're just now still fighting for simply direct access just to see that person off the street. But to think that you guys are possibly going to be able to make such a big jump, I mean that's just exciting when I think about that.
It is a really cool concept, and the developing world has so few physiotherapists, so few medical practitioners, that the last thing we wanted to do was turn out the DPTs as we do in the United States. We thought they're going to be up in the bush, and somebody's going to walk in with a broken femur or a broken humerus or something like that, and they need to know how to set that, put a plaster on, cut the plaster off. They need to be able to inject and suture and things like that. So why not? No one said
Yeah,
no, so it all went through
yeah.
pretty good.
Definitely not the case in the U.S. It seems a lot of other people like to say no to other people, and we won't get into that because there's definitely not
Yep.
enough time in this episode. So, Shala, do you mind giving your contact information for listeners who might want to follow up with you and learn more about what you're doing?
Yes, I am at scunningham4 at radford.edu.
All right. And Richard, do you have any contact information or best ways for people to reach out to you regarding your projects?
Well, two things regarding the project itself. Uh, the website is teachandtreat.org, and they can find out more information. AAOMPT has been extremely supportive. Um, Anyone listening who wishes to be a faculty member, please contact me directly. And my email is rjackson at the Jackson Clinics, plural, there's an S on the end, thejacksonclinics.com.
Well, thank you both for your contact information, and I'm sure you're going to get some excitement built up around the program, around the research, and everything else. So thank you both for your time, and I hope you both have a wonderful day.
Thank you.
Thank you, Kevin.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.